You're still watching the AM show. Tomorrow is World Malaria Day. I've got some statistics to share with you. If you thought we were doing well in the fight against malaria, well, somehow maybe we can't be so specific, can we? Now, check this out. Globally, 3.3 billion people in 106 countries are at risk of malaria. And Ghana, of course, is joining countries yearly to commemorate this event with various activities projecting the country's effort, progress, and challenges in implementing malaria control interventions. So we're recording a lot more cases at the outpatient department, but the good thing is that we've recorded lower deaths if you look at the statistics from 2017 and 2018, which we will be showing you on the screens. So we want to talk about how far we have come in the fight against malaria, what the way forward looks like, and what the challenges are ahead of World Malaria Day tomorrow. My guest is Dr. Nanaya Pepra. He's an epidemiologist and also with the National Control Program, the National Malaria Control Program. Good morning, Doc.
Good morning.
Thank you for being here.
Thank you for having me.
I gave the global statistics, but there's a national one as well. But let me start on the statistical note. How well are we doing in terms of the people who have, or the records that we have in terms of malaria?
Okay, so currently, the latest parasitemia levels we have from Malaria Indicator Survey 2016 shows that we are currently around 20.6%. We used to be around 50 to 70% from a modeled estimates in 22, right? So we've come very far with respect to the parasitemia levels. With respect to mortalities, in 2015 we're recording 2,137 mortalities a year, all due to malaria. In 2018 we recorded 428 cases. I mean, so obviously we are not doing badly, except that we are still seeing more suspected cases. And of course, for obvious reasons, you are having the case definition for malaria is fever. I mean, anybody who has fever, you suspect of malaria. The gap is in testing, because you don't have all the suspected cases being tested, and therefore you don't confirm the malaria before you treat. So those are some of the few challenges we have. But
so what is preventing us from testing all cases?
Yes, so I think it's a behavioral thing. We are not, I mean, we've done well. We used to be around 36%, somewhere around 2012. Now we are 91.7% in testing. So it means we are improving. But by 2020, per our strategic objective, we want to achieve 100% testing, meaning that by 2020, we want to ensure that every suspected case in our facilities are tested. We are doing more training with the prescribers, and we know that people go to the pharmacies and over-the-counter medical sellers. So we've engaged them, and our hope is that as we engage them and we give them the RDTs, they will ensure that when people come, they are tested. And it is very important that people get tested, because our parasitemia levels are going down, meaning that they will get to a point where can be bitten by a mosquito, but you will not have the parasites, because the mosquito will not get the parasite to transmit. So the symptoms people will be showing may not necessarily be malaria.
Okay.
We've had, I've said this elsewhere. I was telling people that we had an instance in Bongahafo where there was an outbreak of meningitis, but because people were doing the usual, or fever, malaria, people were dying. Then later on they realized that they were actually not dealing with malaria, but meningitis. We don't want to get to that point. We always want people to know the exact disease they are dealing with, and they manage it appropriately.
Isn't the anti-malaria a counter drug? You can easily get it when you go to the pharmacy.
Yes.
Okay.
Yes.
So if I go and I describe what I feel I'm going through, now we are saying the pharmacist must test.
Yes.
What's the difference between that test and the lab test?
Great. So the rapid diagnostic test, the one I said RDT, is to ensure that people get their result as early as possible. Most of the RDTs we have in town is for P. falciparum, Plasmodium falciparum. We have mainly 3 species in Ghana. We have the Plasmodium falciparum, we have the Malaria, we have the Ovale. There are others like the Vivas and the Nolesi. We've not recorded any in Ghana. So unfortunately, you have the falciparum being the most prevalent in Ghana and also the most deadly. So most of the RDTs we have deployed is to test falciparum. So if you do falciparum and you are still sure that it is malaria, then you go to the lab where a sample is taken and they look under the microscope. So that if it was a non-falciparum malaria, which was not detected by the RDT, the lab would then detect it for you.
So with what's the explanation you've just given, is it safe for me to go to the pharmacist?
Yeah, because you are almost like close to 97% of the cases are due to falciparum. And the others will even have falciparum plus malaria, which will still be picked up by the RDT. So the numbers we are talking about are very, very small numbers. And we are saying that if you still think it is malaria, don't be like a prophet, you can see malaria, let's confirm it. So if you still think it's malaria after the RDT is negative, let's do the microscopy.
So usually, and this is personal experience, it's thrown to you like an option if you went to the pharmacy. They would say, oh, do you want to test? With what you have described, oh, you can take the anti-malaria, but if you want to test, so it's not like let's test before. Why is it like that? If it's from what you're, it is really crucial that we do that. So why is it not enforced?
See, that's why we are here today. Because we have to engage people. We have to ensure that people understand the need to test. So like you understand. So when you get to the pharmacy, that shouldn't be even an option for you. You are going to get tested first. Because you know that if you don't treat if it's malaria, other diseases that is showing up with the similar symptoms could be more or less affecting you. And you might think it's malaria. People get treated for malaria a week or two, then later they realize it's typhoid fever. You understand? That's why I'm saying that this education is relevant, not just for the pharmacist or the prescriber, but for everybody. So that we insist on getting tested. If the doctor says he suspects it's malaria, tell the doctor you want to get tested.
Sometimes it comes back even when you think you have treated it. And I understand it comes back in a worse form. How can I go through a full course and still have malaria right after?
It doesn't usually happen unless you have the type we call the hypnozoid types, like the P. ovale, the Plasmodium ovale infection, or the P. viva. The P. viva is actually not in Ghana. But if you have the P. ovale, it's hides in the liver. So maybe when you had the symptoms, you usually show symptoms when it is in the blood. So you show symptoms, it's treated. But because some is hidden in the liver, it can then show up again, right? So if you have that type, then you could have the scenario you're talking about. Aside that, it could be a different disease.
Okay. The estimated number of malaria cases remained unchanged from 2015 to 2017. So approximately 219 million globally and 435,000 estimated malaria deaths within the same period. I want to come down to what we have in Ghana. Maybe we can continue on the back of the fact that we're still recording more suspected cases in the OPDs, but the deaths are going down. Is there a particular thing that we're doing specific to Ghana?
Great. So we have a number of interventions. One of the key interventions I really want to talk about today is environmental management.
Okay.
We don't get people to do a lot of environmental management. Like you ask yourself, am I contributing to increasing the population of mosquito in Ghana? So for instance, you have your flower pots. Do you flood it with water? It gets stagnated and it's a breeding site for the mosquito. You have containers where you're using to collect the water dripping from the air condition. It stays there for days. It's a breeding site for the mosquito. You're talking about galamsey. They are creating stagnant places for the mosquito to increase. So we need to encourage people to look out for these things to ensure that we don't create the environment for people, for the mosquito population to increase. One intervention we also have to decrease the population of mosquito is what we call larvicidem. When the eggs of the mosquito are laid on the sites, it develops into a larvae and then to pupa and finally to the adult mosquito. So we drop either biological agent or chemical agent to kill this larvae so that they don't develop into the adult mosquito. We started it in a very limited, in limited areas far back, I think 2012. But we are going to increase the coverage from next month. Another intervention we have, which which I'm sure you ask questions about, is the nets. Right, we've provided nets and it's free. We expect that people sleep under the nets because it's scientifically proven to be working. Most of the countries that are talking about pre-elimination now and elimination use the same interventions. Right, and so we have to encourage people to sleep under the nets, and those are the interventions we have used and have brought down our parastemia levels. We also have an intervention called.
Wait, the nets. What's the difficulty? There's still a big challenge with us sleeping in mosquito nets.
Yes. So people complain about it's the hotness of it, like when they sleep under the nets, they hope it's hot. But one of the things we've realized is that yes, it's some of the texture of the nets. I mean, could make the nets hot to sleep under, but we realize that it's also not just about the texture, it's also about how our windows are placed. I mean, we don't have very good aeration in our rooms, and then we blame it on the nets. People also have adverse events like itchy eyes, itch all over the body when they sleep under the nets, and one of the things we realized was that they don't air dry the nets at the recommended place and the time. Usually you want to air dry, it's a very open place where you can have quite good amount of air blow through it within 48 hours. When you do that, you won't have that reaction. People used to complain about the fact that they don't want to sleep under white nets, because in some part of the country, when you sleep under white, it's like you are being buried. You know, so because of that, we also change the colors of the net. So we are doing everything possible to encourage people to sleep under the net. And I mean, we are not saying that we are not improving with respect to the number of people sleeping under the nets. We are right now around, I think, 52%. But we want to do more.
Is it 52% of people who have collected the nets, or people who are sleeping in the nets?
So ownership, according to Malaria Indicator Survey 2016, was 72%. So like people, the number of households that own a net is around 72%. But if you look at the proportion of pregnant women that sleep on a net, it's around 50%. Children under 5 sleeping on a net is around 52%. Meaning that there's still a gap. You have people owning the net, but they are not sleeping under the net.
If you use all the mosquito coil and the sprays, must you still sleep in the nets? Because sometimes we feel we're protected from all the insecticides that we use.
So we unfortunately cannot approve of the quality of the mosquito nets and the coils we have around. And the ones we can approve of are the ones we have brought in, and we do durability studies on them, and we are sure of the efficacies. And in fact, there are studies to show that even when the chemicals in the nets are gone, it is still effective in the fight against malaria. So we will advocate more for that. We don't want to go into the area where we don't have enough evidence of its efficacy.
Okay. So you are still outlining some of the things that you've done.
So I think I mentioned indoor residual spraying. We don't do it across the country. Very expensive intervention. So we have multimedia can support and get people have this indoor residual spraying is actually an intervention where we spray the interior walls of our rooms with chemicals. And the behavior of the mosquito is such that after biting, after taking its feed, it rests on the walls. So when they rest on the walls, they imbibe the chemicals on the walls and they are knocked down. Because it's very expensive intervention. When we had the money, we had to concentrate on areas where the bedding was high. So we started from Upper West, added on some places in Upper East, and some places in the Northern region.
How often do you have to do the spraying?
I think depending on the chemical you're using, once a year. So we target the raining seasons where transmission is very high. So if you spray it once, you are covered for like 9 months.
Can you privately as an individual also do it?
The way I'm seeing you, I'm sure you have a lot of money.
Oh, it means that this must be really expensive, the way you're talking about money.
No, and we also give it, we did indoor residual spraying last year for the prisons. Because the prisons, we can't ask them to use nets. So we did that intervention for them as well. And it's
and
helping.
how has it helped? Have you gone back? Or?
We've not done studies on that. But I mean, we know that it's indoor residual spraying is known to be very, very effective.
Why are we not replacing that with the mosquito coils and the sprays?
It's about cost efficiency. You're looking at cost, coverage, how many people you can cover with the nets. I mean, we are not saying that nets are not good. They are very good. But relatively...
But the nets are free.
Yes.
So I'm talking about...
And the indoor residual spraying is also free. But it's free at the end user level. But it's not free. People, the donors are giving money. Government is supporting.
Okay, which means it's not something that is out there that any individual can buy?
No, but you can engage the stakeholders. Agama, Anglo Gold, Agama, they are involved. PMI also have an agency involved. You can see us if you're an organization and you're interested in that. It can be arranged for.
Okay, because I'm thinking that if this is something that you can do once in a year, and it will still sustain you, then why not replace that with the mosquito coils, and we'll
We
be
are
good to
hoping
go.
to engage multimedia very soon.
You have a lot of hope, which is very good. So let's talk about children under 5 and why they are most vulnerable. Sometimes you hear a child has died suddenly, and it can be really, really sad. Why are children under 5 most vulnerable?
Yes, it's very unfortunate to have that. But the simple reason is immunity. Children under 5 and pregnant women have decreased immunity. It's like the policeman in you. It's not, I mean, the numbers are not good enough to fight foreign bodies. So like the malaria parasite is like a foreign body. If the immune system is strong, it's able to fight a bit. So unfortunately, because the immune system are not too strong, they are unable to fight, and therefore they go down with very severe forms of the disease. And that is why I forgot to mention an intervention we do in the northern part of Ghana. They actually qualify for that intervention. Studies have shown that in areas where you have the highest burden of transmission within the shortest possible time, like within 4 to 5 months, you recall like 60% of your cases. In those areas, an intervention called seasonal malaria chemoprevention is approved by WHO, where children under 5s, because of their vulnerability, we give them SP amodiaquine. SP is a drug like sulfadoxine pyrimethamine plus amodiaquine. When we give them this medication during the rainy season, it brings down the transmission.
Oh, okay.
Right. So, I mean, immunity is an issue, and we will always be looking at ways and means to ensure that the children don't go down with malaria. And that is why we are bringing in the vaccine as well.
Just before we get would a child under 5, must that child also be tested, or you can read the symptoms?
No. So the child must be tested. You know, children are usually also very vulnerable to viral infections. And so if you don't test, you might think you are dealing with malaria. Maybe you're just dealing with a viral infection, right? Or you might be dealing with a bacterial infection. The child requires antibiotics, and you are giving anti-malaria. You will not win the fight.
Okay. All right. So let's talk about the vaccinations.
Great. So we've realized that with all these interventions, I mean, we are making headway, but for us to really achieve elimination, there is a need to add on. So God being so good, we have a vaccine. It's not an ideal vaccine like with respect to its efficacy. We were hoping to get a vaccine that would be like 100% efficacious, but unfortunately we don't. But the nature of malaria and what it's doing to our children and our pregnant women, if you have a vaccine that is able to reduce morbidity by 30%, 3 out of 10 people are saved from dying, it is very good. Because just one person being saved is very important. If you have a vaccine that is going to save 4 out of 10 children from getting severe malaria, which would degenerate into possible mortality, it's also very significant. If you have a vaccine that is going to reduce anemia related to malaria by 60%, it means that vaccine is very relevant.
So is this what this vaccine is doing?
Yes, exactly. So this vaccine is giving us this levels of efficacy. As I said, ideally, you want like a vaccine that is around 90% and above. And so this vaccine won't be a replacement intervention. It's not going to replace any of the interventions we have. What it's going to do is just to complement the interventions we have. And this vaccine will be for children 6 months. The first dose is given at 6 months. You give the second dose at 7 months, and the third dose at 9 months. Then the final dose at 24 months. We are not doing it across the country because it's a new vaccine, and you have to, you know how it functions in a controlled environment. By now, you should know how this vaccine functions in the routine system, where you don't have control over when the mother is bringing a child and all the other issues with the routine system. And so the approach is more or less like a phased implementation, where you are looking at gradually implementing it to see how it will function in the routine system. So it will be done in some districts in Central Region, Volta Region, Brongahafo, and Upper East.
Okay, why these specific places? So
we selected them at the time when these decisions were taken, far back 2015. The data available was Demographic and Health Survey 2014, and it showed that these regions had a high prevalence of malaria, more than 20%. And they also showed good immunization systems, because you're going to put it in an immunization system. So if that region doesn't have a very good immunization system, it might not go well. Greater Accra, for instance, cannot be included because prevalence is very low in Greater Accra, right? So we considered all these things before we selected those.
Okay.
regions.
So when are we really doing it?
Next week.
Oh, next week, the vaccination?
Yes, next week.
But where does it exist? You know how sometimes people have all these ideas that somebody's trying to test something on us, and because we're poor, in some ways we've given ourselves to be used, essentially.
Okay, so drugs and vaccines in general, they go through phases. Where we are now, it's not like you're now going to be testing if it works. We've done phase 3 already, where Ghana was also included, and we were able to tell all this efficacy percentages I was telling you. So where we are now is really not to say that it's like a testing on chickens or something. No, that's not where we are. Where we are is to see how it's going to function in the routine system. Now, I asked myself, this vaccine is for P. falciparum, the most deadly and the most prevalent in Africa. It is not in Europe. Okay. So where are they going to? Okay. Where are they going to pilot it? You understand? Yes. So definitely it has to be done here.
But has it been successfully done elsewhere?
No. So
in any other country in Africa?
No. So I think Malawi just started it. We're actually doing it with 3 countries. With 2 countries, Ghana, Malawi, and Kenya. Okay. They started last week. Was it yesterday? And we are going to start next week. And I'm sure Kenya will also be starting in a few weeks.
Okay. So, you know, some countries are doing research, you know, people are looking at ways to get rid of malaria completely. Our problem in Ghana has been funding. Yeah. Are we doing it? Is there any research ongoing somehow on our own, homegrown research to get rid of malaria?
You see, getting rid of malaria comes with a lot of science, as you said. And science, you need money. So rather, I want to talk about money.
Funding.
You see, we are talking about science and we want to talk about money. But unfortunately, most of the funds we have is coming from the external world, as in external donors. What are we doing as companies in this country to ensure that we eliminate malaria?
What can we do?
I believe that, see, we are actually putting together a malaria foundation. It was actually there, but we realized that there's a need for us to get it up again, where we are key businessmen in this country will be leading it. And what they'll be doing is to get businesses to invest into that foundation, and then we use the resources in the foundation to target areas where malaria burden is still high, to ensure that we go down. So that's one area. The government, you know, the common fund, it has about 0.5% that is supposed to be channeled towards malaria control. Unfortunately, we don't see that happening that much. We don't see that 0.5% of that common fund being channeled towards the fight against malaria. And so in this commemoration, what we'll be doing is to talking about the need for the 0.5% to specifically go for malaria prevention. Yes, so that if that is done, and if we should also have our presidency and the political leaders keeping malaria elimination high on the agenda, because the countries that have eliminated, it was high. I mean, everybody kept on talking about it, from president to the laborer, to ensure that what can I do? And that is why in our celebration, for instance, we are saying that zero malaria starts with me. So it's not just the political leaders.
So we're personalizing it.
Great. So another area I think we should be looking at is how the corporate organizations. We did a study in 2016 and realized that the burden of malaria on business is huge. For instance, you're doing a nice presentation here. If you go down with malaria, they won't have you on set, right? They're going to spend more money on you. Insurance.
Sure.
Why don't we prevent it? Right. So multimedia, for instance, I'm coming again.
This is about the 4th time you've mentioned multimedia.
So I mean, we are encouraging the corporate organizations to invest into the fight against malaria. So let's ensure that all our staff in our companies are prevented against malaria.
Okay. Well, you can also come and spray this facility for us, you know,
at
so
a
that
cost,
we know that we can be
at a cost.
At a cost.
Yeah.
Okay. Let's finish off with what's going to happen tomorrow. Tomorrow's the day.
Yes. So tomorrow we are doing it at Somanya.
Okay.
God willing, our First Lady will be with us. Our Minister for Health, regional minister, the regional minister will also be there, and hopefully we'll have directors from Ghana Health Service being part of the meeting. The agenda, as I said, is Zero Malaria Starts With Me. So you are going to trumpet that cause and ensure that everybody, it shouldn't be business as usual. Every year we'll come and talk and then we go away. But this time around, we want to ensure that people appreciate the need to be part of this fight.
So why Somanya?
Somanya because Eastern region is currently the highest, right? With respect to the prevalence from MIS, Eastern region is the highest, around 31%. And so we're looking at a place where we could do it and ensure that, or if it's Eastern region, get a place in Eastern region, get it trumpeted and get it drummed into the people over there and ensure that they change their behavior, take up the interventions and reduce the burden. Okay.
All right. Finally, just, final personal tips. As you're hammering on, it starts with me. So what should we do? Just final tidbits in like 30 seconds.
Great. So sleep under the net. If you are pregnant, when you go to the facilities, ensure you take SP, sulfadoxine pyrimethamine. If you're in the areas where you have SMC, ensure that your child gets the drug. And if you're in areas where you have IRS, ensure that your rooms are sprayed.
The bit about the pregnant woman.
Yeah, so the pregnant woman, I mentioned the fact that their immune system are also down. And so they're also at risk of severe malaria and its consequence on the unborn child. And so we give them a drug called sulfadoxine pyrimethamine. 16 weeks, when they are the pregnancy at 16 weeks, we give this drug, and monthly until delivery, we give this medication, and it's for free. So when they go to the facilities, we ensure they get this medication.
So if they are not giving it to you, you can ask?
Yes, you can ask.
Okay. Yeah. All right. Thank you very much for your time.
It's a pleasure.
And we will be following through with the celebrations tomorrow, but we're opening our doors for this free spraying as well. That will be good. Dr. Nanaya Alpefa has been my guest.